Get that. All right. Well, I'm just going to make a quick discussion today about disc herniations as it relates to like an accident and patient communication around disc herniations. So, so I work with a lot of car accidents, and in the car accident cases, that means you're going to see a lot of MRI reports, and sometimes the MRI reports don't come back until a person has been in care for a few weeks. And so it can be challenging when you get a report back on how to communicate properly with the person. And I just want people to, if you're in clinic and you have to work with folks that are in back pain and may end up getting an MRI, just things to keep in mind when you're going to discuss, how care will proceed from here, because this is a recent one. I got the reports right here, and a gentleman in his late 30s, manual labor job. So he's in a car accident, and we get the MRI reports back about 3 weeks into care. Now we've got disc herniations, L3, L4, L4, L5, L5S1. 3, 4, 5 millimeters. They protrude out and get some annular tears, things like that. Stuff that can sound very scary to a patient when you go read it back to them. And one of the first things you need to consider is how are we treating the patient now? How's the patient feeling at this point in care? Because it's always challenging to get a report back that has some injuries to the disc that you're going to have to discuss with the patient. But the flip side of that is the patient's 3 weeks into very conservative management, extremely non-invasive. We're doing mostly passive things at this point because we don't have, especially with auto accidents, we're always a little more careful as we get started. And you turn around and you talk to the patient, and they're back to working, manual labor job, late 30s. The likelihood of these disc herniations being there prior to the accident is extremely high. So we can't even say for sure that any of this stuff was caused by the recent incident. It's just that there's some irritation of possibly some of these old injuries now. And when the patient comes in originally, they weren't even complaining about that much low back pain, kind of 2s and 3s, maybe more stiffness than anything. And at this point, by the time we get the reports back, patient's already, like I said, back to work, back to doing normal activities, feeling pretty good. It says it just feels tight sometimes in the low back. So you have to really make sure that when you turn around and discuss the imaging results with them, that you frame everything in a way that isn't going to create some unnecessary confusion or unnecessary concern in the patient, and start having them have setback or relapse in feeling and care. Because sometimes people will hear these things, and if you frame it in a way that makes the disc herniation sound scary, sound like they're going to have a permanent problem, doing things like that, which a lot of people do, depending on what kind of care they're after with a patient. Because depending on what's going on, many people see, oh man, I've got these bulges and herniations and things on this report, so I've got an opportunity to really extend care. I've got the opportunity to really code higher and create, get more billing out of it and things like that. But to me and the pain physician I work with, we look this over and we think, okay, how is so-and-so feeling today before we read the report? Oh, he's back to work. He's almost pain-free. He says he just feels a little stiff sometimes in the mornings. That's great. Now we need to make sure that when we approach the discussion of these 3 disc herniations, that we frame it in a way where the patient believes that they're still on the right track, believes that the care plan that we are working on is going to continue to help them improve, and we don't make them fearful of these things being there. and making sure they understand that there's a chance that these were there before, but they probably just got irritated by the accident. Don't you realize that you're improving already with the care that we're doing, and so we don't want to create unnecessary worry around the injuries to the disc that we're seeing, because these things, like I said, may have been bothering, or probably there before, weren't bothering him then. Maybe he had some stiffness and tightness here and there when he was working, but never really thought much about it. So we have to avoid that situation where just trying to explain the report to the patient gets them concerned and worried and starts to make them feel like, oh no, these injuries to my disc. Now I'm going to be in trouble permanently, which is not true. If mid to late 30s manual labor job, we could MRI every single person in that category, and we're going to see probably at least one disc herniation with an annular tear or something like that, regardless of any back pain. So we just always have to keep everything in context with people, reassure them that staying the most conservative, the least invasive, and doing the least amount of things to them while encouraging them to get back to as much normal work and activities they can tolerate is still the best course of action. So, with that said, just make sure that when you guys work with patients where advanced imaging is kind of routine, like it is in auto accident cases, or if it's something that you decide that you might need to get on a patient while you're working with them, just keep in mind how you go about explaining the findings to the person. And if they're already progressing well and almost back to complete normal by the time you get a report, just make sure that when you have that discussion about the report, keep it simple, keep it concise, and make sure that when the report of the reading of the, or when you're done reading the report with the patient, they leave feeling confident and encouraged that they're still on the right path.